Hello, thank you for joining me today and letting me talk about my specialist topic, the pharmacokinetics and how drugs transfer into breast milk. I hope that it will help you to prescribe more easily for breastfeeding mothers that you meet within your practice. So first of all, who am I? Um, I was born over a boot shop more years ago than I'm going to admit to, and perhaps inevitably, I became a community pharmacist. I also was the mother, or am still the mother, of three grown-up children, and developed a passion for breastfeeding along the way, partly because I have Crohn's disease myself, and found that I was healthiest whenever I was pregnant or breastfeeding. It was suggested when I had trained to become a breastfeeding supporter that I perhaps put the two roles together and look into more depth on how drugs pass into breast milk. And as a result, in 1995, I began a PhD looking at the experiences of GPs, pharmacists, and mothers in a matched area. Unsurprisingly, the experiences weren't necessarily the same. As the Breastfeeding Network was formed in 1998, I began to operate a service called the Drugs in Breast Milk Helpline, where I answered, initially on the telephone, later through social media and email, questions from mothers and professionals on the compatibility of drugs and breastfeeding. Along the way, I have written 5 books to try and make it easier for other people to access the information and not keep the knowledge to myself. During my time with the Breastfeeding Network, I answered anything up to 10,000 queries a year from topics ranging from, is it compatible to use nail varnish remover whilst I'm breastfeeding, to when can I go back to breastfeeding because I used 2 lines of cocaine last night. In 2019, I had the very great privilege of being awarded an MBE at Windsor Castle by Her Majesty at Queen for services to mothers and babies, something I never in my wildest dreams thought would happen because I was just following something that I was passionate about, the same as we all do on a day-to-day basis. And it was an immense honour. When I first started my PhD, I told my supervisor that the one thing I didn't want to look at was the pharmacokinetics of how drugs passed into breast milk. It sounded way too complicated to me. I wanted to look at the qualitative experiences of the mothers, doctors, and pharmacists. But inevitably, I got drawn into the science. And now this forms a large part of my life. But I hope to be able to explain it in more simple terms so that you can use it on a day-to-day basis. And I'm assuming that most of you would not have covered this in your undergraduate training and may not have met it during your professional career. But by using pharmacokinetics, we can evaluate what the risk is of any drug passing through breast milk and look at whether it's necessary for us to manage a mother's breastfeeding by timing the drug and her breastfeeds. And I also want to look at how do we support the mother to feed as she's chosen, be it to exclusively breastfeed, exclusively formula feed, or combination feed. But breast milk is about so much more than just milk. It's about a massive comfort to the baby, a relationship between mother and baby, but it's also about the lifetime health benefits for mothers and babies. And it is inevitably part of the health promotion part of our roles. And hopefully by the end of this brief session, you'll be able to balance the risk of the drug passing to the baby with the risk of not breastfeeding at all. So the most drug passes to the baby in the first few days after delivery because there are wide gaps between the alveolar cells to enable immunoglobulins to pass through into breast milk to protect the baby's gut, align it with all the special properties that stop gut infections, urinary tract infections, because when the gut is coated, any of this special lysozyme white paint that is left goes on to coat the urinary tract. The more I've learned about breast milk, the more I'm boggled about what a wonderful tool nature has given us. But in these first few days, we probably prescribe more to a breastfeeding mother than at any other time. She may have had an anaesthetic for a caesarean section or an epidural. She may need antibiotics. She'll almost inevitably need some degree of analgesic. She may need laxatives. But we use this by custom and practice. It's something that we're very familiar with, and there are much less concerns. But after the first few days, these alveolar cells close up. So in order to pass into the breast milk after this time, drugs have to pass across cell membranes, and it depends on how ionized or unionized they are, how fat soluble they are, how easily it is that they can get through. Drugs which are highly protein bound are the safest to use in breastfeeding because it means that very little is free to pass into breast milk. The rest is captured in her bloodstream. And now, in an ideal world, we want drugs which are bound by more than 90%. So sertraline, for instance, has a plasma protein binding of 98%, whilst ibuprofen is more than 99% protein bound, which explains why so little is available to pass into milk. But you won't find this kind of data in the BNF or on your computer system. We need specialist sources, which I'll tell you more about as we go through. The other thing that I look at when I'm looking at a drug is the half-life of the drug. So I'm sure you remember about this, but it's the time that it takes half of the drug to be metabolized. And after 5 half-lives, it's assumed that all of the drug has gone from breast milk. But if the half-life is more than 24 hours and we're giving the drug daily, then it may begin to accumulate. For instance, diazepam has a half-life of 43 hours. So if we were to give a 7-day, 3 times a day dose, the baby might well become drowsy in this time. But a low dose over 1 or 2 days for a muscular, for instance, back spasm, doesn't seem to affect babies, and we can still use it in that way. Fluconazole, which is often used for ductal thrush, has a half-life in babies less than 6 weeks of 88 hours. And even with older babies, it's 30 hours. And when I see it being prescribed for mothers who are experiencing intractable nipple pain, it always concerns me because this is often in the first 6 weeks where actually the mother has never been able to achieve pain-free breastfeeding. And the baby may start to vomit, it may start to lose weight as a consequence, and I have seen one about to be admitted for surgery because it was assumed that the baby had pyloric stenosis because it was vomiting so severely. In actual fact, the mother hadn't ever had any breastfeeding support, and that was what was needed to give her pain-free breastfeeding. I was partly involved with writing a leaflet on thrush back in about 2000, and we were looking at cases where mothers had been breastfeeding pain-free for a significantly long period of time, but suddenly it became excruciatingly painful. Nothing we did seemed to fix it. After a lot of research, we found that this was associated with thrush in the ducts, but it was usually accompanied by nipple damage as well. But it suddenly seemed that fluconazole was the drug to cure all breastfeeding problems, and it was given out very widely with, as I say, commensurate problems. Um, Nowadays, I'm very reluctant to agree that its prescription is useful um, under 6 weeks, because most of the time there is something like a tongue tie that hasn't been fully evaluated. Other data that we need to consider is oral bioavailability. So, for instance, antibiotics that are only available IV, such as meropenem, teicoplanin, gentamicin, aren't absorbed orally, so it doesn't matter how much we give to the mother, the baby won't be able to absorb any from breast milk. The same is also true of the contrast media that we use in CT and MRIs, and in the biologicals that we use increasingly for inflammatory bowel disease and rheumatoid arthritis. The milk plasma ratio is the ratio between the level in the mother's milk and the amount that gets through in her that is in her plasma. Sorry, I didn't explain that very well. The amount that is in her plasma compared to the amount that is in the milk. If the level is over 1, it suggests that the drug is actually concentrating in milk. So, for example, alcohol has a milk plasma ratio of 1, but as the level in the mother's body falls, the alcohol comes back out of the mother's system. Whilst cannabis has a milk plasma ratio of 8 and iodine of 26, showing that they do very definitely concentrate. And even using an iodine dressing for a C-section wound could mean a significant level in the maternal milk. And the last is a number that was first developed back in early 1990s, which is a relative infant dose, which is calculated as in the slide. And it's believed that a level less than 10 is an indication of compatibility. But we can't take any of these data in isolation. We need to have all of the bits fitting together to give us a full picture. Many women will try to avoid feeding at what they assume is the peak level in breast milk. So they'll do things like take an antidepressant at night in order to take it before their baby's longest feed. But in actual fact, if we take a drug every day, by the time it's gone through 5 half-lives, it's in a steady state, and the peaks and troughs are minimal. And trying to time feeds with drug taking is virtually impossible with any chronically administered drug. It has a degree of usefulness with an acute medication, but babies don't feed by the clock. They feed when they're hungry, just the same as we eat and drink when we're hungry. So trying to time drugs and feeds just leads to more stress. A few years ago, it was routine practice for women to be told that they couldn't breastfeed for 24 hours after a general anaesthetic, or following midazolam for sedation for maybe a colonoscopy. The actual evidence for these was very, very poor. And some guidelines were produced on the 1st of August 2019, which says that any women can continue to breastfeed after anesthesia or sedation as soon as she is awake and alert. Looking at the risk benefit, the risk of not breastfeeding for 24 hours means that she's actually at risk of mastitis and consequential antibiotics. So these guidelines should be used in all procedures. To pump and dump milk for a breastfeeding woman is one of the most heartbreaking things that you can ask her to do. And it's very, very rarely necessary. If it is necessary, then we need to make sure that the mum A, has access to a breast pump, B, knows how frequently to feed in order to maintain her supply, and C, when she can go back to breastfeeding again. And if you're unsure, rather than say just pump and dump, by all means ask her to pump, but maybe suggest that she keeps the milk whilst you find time to check the resources, time which you won't have in a general appointment time. Once it's thrown away, it's down the drain, and she may be crying over that spilt milk. I've given some examples here of the data on how much drug gets through in breast milk using the plasma protein binding, relative infant dose, etc. The one of these that I would pick out is the use of codeine in breastfeeding. In 2013, the MHRA issued a directive that codeine should not be prescribed for breastfeeding mothers because there was one mother and baby pair in America where the baby died some 14 days after birth. The mum had been prescribed it post-cesarean section, and she kept saying it made her feel very unwell herself and that the baby was incredibly sleepy and wasn't waking to feed. Her baby's paediatrician just told her to go and see a lactation consultant, although he did lower the dose of codeine. It happened that this mother's metabolism concentrated the morphine, the metabolite of the codeine, in her breast milk, and the baby actually died of an overdose of morphine. There had been plenty of times when this could have been picked up because of the undue sedation and the fact that the mother didn't tolerate the drug well herself. So a few people metabolize it and are perfectly normal, don't have any side effects, good analgesia. Some you can increase and increase the dose, and the metabolism is so fast that they get no benefit from it. And this other group of people who find that the side effects are very high and that their babies become sleepy are the ones we really need to avoid. Dihydrocodeine is metabolized in a completely different manner and is subject to extensive first-pass metabolism and is the opioid of choice, or oral morphine if you need a strong painkiller. There are nice guidelines which suggest that we need to look at specialist sources rather than just using the BNF, and acknowledging that if a mother does stop breastfeeding, then it may be very difficult for her to go back to exclusively breastfeeding. And the same is actually also true if you ask her to pump and dump for any length of time. There is an initiative that was launched a few years ago by the MHRA, which included the NHS and regulators, together with the third sector, looking to alter the information about prescribing so that it was easier for the prescriber and also made for shared decision-making with the mother. So, for instance, you might notice that things like sertraline will now have in brackets in the BNF according to expert opinion. Before, the BNF just relied on the manufacturer not taking responsibility, so virtually no drug was deemed compatible with breastfeeding. Now we're trying to provide more information. But it's a very, very slow process. The NHS does not rush itself. So we need to remember that breast milk doesn't turn off like a tap. We can slow a milk supply down by losing one feed at a time. But if you ask a mum to stop suddenly, she may develop mastitis. And not only all babies will feed from a bottle, so you may get a dehydrated baby, or you may have one that is intolerant of the cow's milk protein in formula. In trying to do no harm, sometimes we can actually cause harm. So which drugs do we choose whenever we can? We need to look at the specialist sources of information, which I believe is on the next slide. Anything which is licensed for a child is compatible with breastfeeding because the amount getting through breast milk will never reach the therapeutic index of the drug given directly. And we may have to use drugs which are not necessarily the newest. So for treating hypertension, we might need to use enalapril rather than ramipril because we have more data on it. And the pharmacokinetic data we need is about oral bioavailability, plasma protein binding, half-life, milk plasma ratio, and relative infant dose. One day, I'm hoping that these may appear in the BNF. These are the reference sources. All bar Hale are free for you to access. LactMed is an American database. UK Dialas is part of the UK Medicines Information Service, and you can phone them up and ask specific questions. I have written some information sheets for BFN and also put some more recent ones on my own website, which I hope will just speed up the process for you. Hale Medication Mother's Milk has virtually every drug you could think of in it, but it is a pay-to-access or a hardback book. As healthcare professionals, we can use evidence-based sources to check the compatibility of drugs in breast milk and be sensitive to the needs of mothers around their infant feeding. We can reassure them and not suggest by hesitation or unknown body language suggest that the baby may be harmed. If you have a question that you want to ask, please feel free to email me at any time. I'm one of these sad bunnies who carries her phone everywhere and has these databases on apps. If it matters to you and your patients, it matters to me. Thank you very much for listening to a rather whistle-stop tour, and I hope that it's helped.